So next, thank you. We are going to Haytham Hamid and/or Jack Parker on the topic of current and future applications of artificial intelligence in aortic disease.
Hello, everyone. Can you hear me?
Yes, Haytham, we can hear you.
Okay. Hello, everyone. I'm Haytham Hamid. I'm one of the vascular surgeons in northeast of England, and I'm going to talk today about current and future applications of AI in aortic aneurysms. I would like to thank the BEC organizing committee for the kind invitation, and I'm hoping I will be there in person next year. These are my disclosures. So if you look at the current practice of aortic aneurysms, certainly in England, is basically we rely mainly on the threshold of 5.5 centimeters. There are some areas where they rely on 5 centimeters on females. And then the patients go through the various assessments and MDTs to reach an outcome of whether they can be fit for surgery or not. But this approach is not without flaws. Um, Starting from loose misdiagnosis in imaging in the report to doing too many images to follow these patients up. But even with the diameter of 5.5 centimeters, some patients might rupture before that. And all of this is time consuming from admin point of view. If you've done more than 400 EVARs, you'd probably be looking at more than two scans every day for surveillance. So how can AI help with that? The concept is not new. This paper from MIT in 1986 it was talking about artificial intelligence in clinical decision making. So it's almost 40 years old, but it's gaining momentum. It's been gaining momentum over the last few years. And you can see that from the FDA approved medical devices based on AI, over the last few years, it's been getting up until it exploded last year, where we have 950 devices registered by the end of the year. So how did it start with aortic aneurysms? It started with a simple thing where they can it measure it below 3 centimeters or above 3 centimeters, and if it is above 3 centimeters, it will highlight it to the reporting radiologist. But that has gone more advanced to detect the maximum diameter and give you an exact diameter from the scans, which will help in detecting those patients. And from one segment, we move to the 7 segments in the aortic arteries, where you can get different levels of measurements from the aortic arch to the iliac arteries. But not only CT scans, it also worked with ultrasound scan when an untrained radiologist or a radiographer can just use an ultrasound probe and the AI may be able to detect the aneurysm and measure the diameter, which can help hugely in screening programs. Some of these applications have made it to the market or to the practice. And this is the first FDA application, which can detect aortic aneurysms and whether there are any emergencies related to the aortic, to the artery in general, like dissection, and can highlight it to specific teams so they can act on it urgently. But diameter is, as we said, is not the only thing. We've tried before to use the volume measurement, the biomechanical markers in different papers to try to identify those patients who had an accelerated growth or high risk of rupture below 5.5. And AI can certainly help with that by measuring the biomarkers and getting an algorithm where it can detect the accelerated aneurysmal growth for more than 2.5, for example, per year and highlight those. But if you combine those with actually patients with a normal morphology and the clinical data, it could potentially get you to an area where you can identify patients who might rupture before 5.5 centimeter mark, or the patients who will grow to that level and they need intervention compared to the patients who will remain stable. It is early stages, but it looks promising. Furthermore, it can help with your images as well, where this paper from Oxford, they used a kind of concept similar to the Hounsfield unit to try to detect the aortic aneurysm lumen based on an uncontrast CT scan. And if you look at these, the second column is the CT scan, the contrast CT scan, but the two AI algorithms are detecting similar pictures from an uncontrast CT. So moving forward, if you the indication there is indication for treatment, it will help you with your pre-operative assessment as well. We're detecting all the data and give you a mortality risk for those patients. But also it can use what we call the radio mix, where it can look at the, for example, the intra-abdominal fat and the psoas muscles, and based on them, it can give you an operative risk for those patients. And it is getting there. The sensitivity is high, but the specificity is still something people are working on. Moreover, it will work on the planning as well. And we see in the different areas where it can measure the diameter. But for example, there are some applications now where it can measure give you a report with diameters on them, which will help you with your planning. It is quick and it just gets as soon as the CT scan is done. Another area which is working on is, for example, all of us have been there where you deploy the stent and you wish the stent had been in a different position or it behaved differently. So people were looking what to do there. So we took the concept from the digital twin, which is kind of famous in the automotive and aerospace industries, to use it in the aneurysms or stenting on EVAR. And this is one of the papers where they look at how the stent will behave before deploying it in a patient. And it looks at 16,000 data points for each patient to look to see how the stent behave. And they had results from 5 years, and that came from Predisurge, where now you have what we call the Endoli risk index, where when you put the graph data that you want to use, and it will tell you whether there is a high risk of endoleak or a low risk of endoleak. It also works on fenestrations, where it shows where the branches and fenestrations position sit, and whether they will be in alignment with your visceral arteries. But in addition to that, there are papers coming out where it can predict from the preoperative scan is that how the stent will behave afterwards and how the patient, whether the patient will have any complication after postoperatively. And that prediction coming from the radio mix is really helpful to tell you whether you should go for that intervention or not. But when you put your patient on the table, then the AI can help through fusion images, where it gives you like a lane keep assist in the cars now, with the go and no go zones, where you can deploy your stents, and it shows you where you shouldn't or should land your stent. But also once you've done, when you completion angiogram, there's this paper that talks about the detection of endoleaks, and actually it'd be helpful to have another pair of eagle eyes to look at endoleaks, because it's a super fast radiologists and surgeons by doing so. So once that is done and we went for your postoperative follow-up, again, it helped with the size measurement and the sac expansion, but also helped with detecting endoleak automatically and highlighting them, as well as trying to predict the aggressive endoleak on those patients, and so you can intervene on them early before you get any sac expansion. So it's early days, but it's progressing quickly. There are, of course, challenging ahead based on the case volumes and whether registries that we have, for example, the NVR registries in England, that can help with adding more patients to the AI algorithms. Obviously, it's difficult to predict how healthcare systems are going to integrate with that, especially with the information governance. For example, in NHS England, all the AI devices or programs are considered as medical devices, and they have to go through all the regulations and standards. But either way, AI is here. So as my message is, we need to get more involved with it, and it is the biggest innovation of our generation and lifetime. And the more we work with it, the more accurate the AI will help us in the future. And I really, when I started this presentation, I asked Gemini, what should I talk about? And it gave me these points which I used. And basically, AI will help us on personalized surveillance, optimizing surgical planning, real-time monitoring, and remote monitoring as with follow-up, and it will enhance our decision making. Thank you so much. I'm happy to take any question.
Thank you very much, Haytham. You've obviously shown us different areas where AI could be used in the management of aortic cases. Which one of those do you think is the most likely to see the first widespread use of AI in the aorta? Is it going to be in the planning for the companies of fenestrated cases, or is it going to be in detection of hospital X-ray departments where they're missing cases? Where do you think it's going to be used most of all first?
Thanks, Mr. Reid. So basically, the detecting cases in hospitals is already there. So, but we haven't been to the stage of using aneurysms. Now, locally, for example, the CT head and X-rays are now reported by AI and then verified by radiologists. So it won't be long before we're getting CT abdomens checked by AI as well. So that's coming in the next year or so. But also planning as well as have been, so there are two algorithms for programs now have been CE marked. Predsurgery, which I mentioned earlier, is now helping planning with in the enduring graft with Medtronic. So they're using that. The Vera Aorta is also CE marked, and there are some centers are using it. So it is picking up quickly, and I think in the preoperative phase, because you can rely on retrospective CT scan to teach the AI and look at those patients within 5 years and what happened to them. So it can predict what happened to in the preoperative phase on those patients. So that will be the first area where it comes. Integration with CR machines or hybrid theaters to be used intraoperatively is still, lagging behind. But looking at all the programs and everything, it is exploding, and there are a lot of companies that are helping the healthcare systems to try to find AI programs that could help in healthcare.
Thank you very much indeed, Haytham, for doing that from the UK. Any thoughts from you two of any of the papers that have been done so far?
Let's talk about AI.
Yeah.
Let's ask who is actually using AI in their current practice for EVA or whatever.
Haytham. No. One or two people are in the room beginning, yeah.
Who is using it?
Well, Dr. Jackson here is looking at the use of AI in carotid artery plaque morphology, because it's been shown to predict stroke not only in asymptomatic patients who've had an ultrasound scan, but in patients going through intervention. And she was presenting this yesterday, but there must be more people in the room that are actually seeing the introduction of AI. No? Not, no? Imaging, yeah.
In radiology.
So Gloria, what are you doing with the prostate examinations? How is AI dealing with that? Is that on MR?
Yes, MRI of the prostate, and it's showing the prostate and the zone which is more shows the zone which is more suspicious, and gives AI RATS assessments like PI-RATS system. And if it's suspicious for malignancy, it will put higher number for this area. We use it also for chest x-rays. It gives conclusion, for example, consolidation or pleural effusion, and also for CT of the head and MRI on DWI imaging, whether there is ischemia or no.
Is this in collaboration with Philips?
G, I think, yes. But it's not so good. Our chief of department, it's not happy with the result.
So I think one of the most underrated and underused features of AI in medicine are fusion and fusion-assisted AI, because all of us do endovascular cases, and we can use currently fusion and AI-assisted fusion because it's built in our systems by Philips and by Siemens, but it actually is very complicated. So whenever we do a custom-made case, we have a technician from Philips coming and setting up everything. But there is a company called TIN, you know TIN? TIN. So TIN, they used to do, you know Frank, TIN, they used to do, I mean, they're still doing C-arms, high-resolution C-arms, and they have recently acquired Terraneva. Terraneva is a company that builds endosize we use for sizing. And now they have AI, very friendly AI tool. It's called EndoNote, so which you can link to the C-arm. And actually, when we do an EVAR on that platform, a standard EVAR, not a custom-made, actually you don't have to inject contrast till you open the graft. You know? So I think it's a nice feature of AI, and it's very friendly. So, I think the idea behind it, if Philips and Siemens would invest a little bit more in doing the AI friendly, and the fusion will be used by more of us.
I wonder what Einstein would have thought of artificial intelligence.
We'll never know.